lot of, I think, really, really interesting studies that are going on right now. And you actually alluded to this issue about the lymph node dissection. I remember that when you look back at the data from Memorial, I think the median number of lymph nodes that were removed were 8. And we often see a large variation from outside of our institutions as far as what the lymph node dissections, how many lymph nodes are taken. So what studies are now being evaluated to look at that particular question?
It's a pretty complex question in the first place. So I think let's take it from various aspects. The first one is actually, there's a study by Copy and colleagues from our institution asking a simple question, is if we look at the increasing number of nodes, is there a higher limit? And in point of fact, actually, that curve just kept going up. And I'm not certain it's the exact number of nodes, but I think it's how meticulous the bilateral node dissection is and how far up does it extend. There are studies looking at defining a dissection, up to the bifurcation of the iliacs versus up to the bifurcation of the aorta, and whether that greater or extended lymph node dissection makes a difference. Some people are carrying it further to the inferior mesenteric artery, which I don't think that 2.5 centimeters really makes a big difference. But in terms of the pathologists in the review, that also is complex as well, because Bernie Bachner did a study looking at patients who had a dissection both sides, same surgeon, but on one side he sent one whole packet, on the other side he sent 2 separate packets, and the dissections that had 2 separate packets had more lymph nodes. So we're using the number of lymph nodes as a surrogate with regard to quality of dissection. I think we do have a randomized trial looking at the level of dissection, a so-called standard dissection versus an extended dissection. We'll see if that plays a role. I think that that's an important study. And then I think the other issue is that we need to export this to the community. If one looks at the national data, 40% of patients in the United States who have a cystectomy and a pelvic lymph node dissection have 3 or less nodes in the dissection. And in fact, that study showed only 12% of patients who undergo surgery actually had 10 nodes or more. So we really need to get that quality of surgery out into the community, I think.
And it certainly can have a very, very drastic effect on the results of a large randomized trial if the surgery is not consistent from institution to institution.
And that's actually in the adjuvant studies, those studies actually control for the number of lymph nodes, which is an indirect way of controlling for the quality of surgery.
Exactly.
Actually, in the SWOG trial as well, the extended versus more limited lymph node dissection trial, they do qualify the surgeon. They have to first be observed for 5 surgeries, and so it's very clear that these are qualified surgeons to do these dissections. So I think it's a good point.
Yeah, it's actually, we actually just went through our qualification process, so it's actually quite extensive. We have to take photographs of the lymph node dissection while the patient's in the operating room to confirm that this is actually being done in the way that the study has mandated. So I think we should get some good clear answers out of that particular trial. I think the marker question is extremely important because clearly we don't want to give ineffective chemotherapy to a patient who may be resistant up front. And one of the things that we're doing right now in SWOG is we're doing a randomized trial, something called Coxin, which is a way of looking at the molecular profile of the tumor. It's going to be done retrospectively. Patients are randomized to either GEM-CIS or extended dose MVAC. But certainly we may understand more about the marker patterns and profiles in terms of response and prognosis.
Yeah, it's an interesting profile because that's actually derived from cell lines, not necessarily bladder cancer cell lines, but derived from cell lines looking at sensitivity of individual drugs. It's really a novel idea, and the most important thing is it's being tested in a prospective study. And that's what we really need for these market development trials.
And we can't emphasize enough the need for putting patients on trials such as these to understand biologically what's going on and how to move things forward. So a patient